Okay, so this class is being recorded as the others have been, and hopefully you saw where they're posted in each of the classes for the recordings. How are you all doing? Everybody's good? Hanging in there?
Hanging in there.
All right, well, that's all we can do, right? So, any questions to begin with of anything that we've covered so far? Or what you listened to for this particular lecture on home care and hospice? Burning questions?
I have
Ophelia?
a question.
Okay, go ahead.
So in the voice thread that you posted for today's class, pretty early on slide 3, when you introduce case management and the health delivery model,
Mhm.
you mentioned a few other models like in the voice thread. I didn't know if you wanted us to go on and look at different models besides just the healthcare delivery model.
No, just the healthcare. I did listen to it again because I tried to refresh my memory because I had recorded this one earlier in the spring. But anyhow, no, you just need to know about the actually the specific models per se. You don't. Hold on, let me admit one more person. Okay. Oh, I see. I had the brokerage, the interprofessional. No, just know that there are different models, but you don't need to know specifics about that. Okay.
All right, thank you.
Mhm. Ophelia, do you have a camera to turn on, please? So I can, I'm sorry, my camera won't turn on. Okay. Well, if you can get it to work, that'd be great. Thank you. I know that's part of the protocol, so. Okay, so I know on, when was that? A week ago, actually. We talked about the different roles for the community nurse, and we talked about med management. So, and we didn't get a chance to do that case study. So I'm going to hold off on that because we do have a lot to cover today. And if we have time, we will go ahead and that was the one about the two different nurses, Violet and Violet and Nurse Karen. So we'll get to that if we have time. If not, I'll post it and you can use it with the answers so that you can use it as part of your studying. Okay. All right. So for today. So in terms of the case management, and I had mentioned to you guys that case management really is a very broad term for a lot of different roles for a nurse in a case management role. And so pretty much what I have in the slides is what you need to know, again, without going into great detail about the different models, but just where do case managers work? What kind of work are they involved in, as far as their role? And then I also mentioned about discharge planners. So hospitals in some cases have case managers. Some have discharge planners that either work for the hospital or work specifically for a home care agency. And so they really work, they're all part of the team. Have you guys had any experience working with any discharge coordinators or case managers in your clinical settings? Probably not, I'm afraid, because you all started when the pandemic started, so that kind of limited, I guess, some of your experiences in the hospital. But in the hospital, they have the team that rounds on patients, and they have case managers, and again, the discharge planners sometimes are in the role of case manager, or they may be a separate role, but they discuss the discharge plan for every patient, and you've heard discharge planning begins with admission to the hospital. So the role is extremely important because the idea is to discharge a patient and prevent readmissions, particularly if they're readmitted within 30 days. Then the hospital, that's a poor patient outcome. And the idea is to get them home to a safe environment with the proper equipment and services that they need in their home or wherever they're being discharged to, so that they don't return to the hospital within that 30 days. Did you all watch the video on the transitional care model? Out of University of Pennsylvania, actually. Mary Naylor, who was the nurse theorist for that model, she was my instructor when I was in nursing school, and she's really an awesome dynamite lady. And when I saw there was a video that she has on the transitional care model, I thought, how great is that? Because that, oh, sorry, I usually put that on silence. But the idea is to and they're beginning to use that model of care in other areas, so that nurses continue to follow patients that are high risk and do go home. They continue to follow them so that they don't end up back in the hospital. So that whole idea to continue to case manage somebody at home. I talked to you about home care and the Medicare and Medicaid and insurance regulations, but in this transitional care model, that is not under the home care model for reimbursement. So it's a little bit different, and they're starting to have those types of models of care in other cities, in other areas as well. They're finding that it just makes sense for people to be at home with as much support as possible, because it's cheaper than bringing them back to the hospital. So, so that's the whole idea there, is particularly, you look with the transitional care model, and I put a copy of it, the criteria for someone if they meet that. So if somebody is a high risk discharge, consider what other services they could use, and ensure that happens. And I think what happens so often is nurses get so busy and so caught up on so many other things that we really don't focus on, and we need to switch and shift our focus to these patients going home and really consider what is happening on that discharge, and is it a safe place for them to go back? So that, meaning, are they able to manage at home, or is their family able to manage them? And I gave you the example of what happened with myself and my husband when he had his foot surgery in January. They were going to discharge him. They gave us very little instruction prior to the surgery of what to expect, and to ask us about our home, to ask us about what equipment. Fortunately, I was able to, navigate that. But what about the people who don't know how to, So it really, really is important for nurses to think about, what does that patient need, particularly when you're talking about older patients that are being discharged. An elderly going home with their elderly spouse. How are they going to manage? So really, really a critical role for a nurse, I believe, is to, and I'm talking about even the med-surg nurses on the floor, because you're part of the team. So you've got to say to the case manager or the discharge planner, hey, I'm really concerned about this patient. Do we have everything in place so that they have a safe discharge? Okay, it's critical. The other piece about the discharge coordination is the medications. And I talked about that in other, I've already talked about it, but I'll continue to talk about it, because medication reconciliation is really important, that the patients know exactly what they're supposed to be on, that any of their meds that they used to be on, we clarify with the doctor, hey, they didn't have this on their discharge instructions. Should they be back on this med, or when they're going from one level of care to another, that there is a discharge list with all the medications. So again, medication reconciliation is really critical piece of the discharge process, is to have those meds reconciled. Does that make sense? Do you guys have any questions about any of that?
I have a question.
Yeah.
So, so you say you have an elderly person or someone that doesn't, maybe have full, like they have an altered state of consciousness or something like that, and they don't have a good support system or someone, a caregiver. So is that when you would want home care to come in to make sure that they're taking their, because I mean, I know that, like, say someone has dementia, they're not going to remember all the time, right? To probably take their medications properly, or even, I mean, the right dose. So, you know, so is that when you would just, would it be our response, like a care coordinator is the one that calls home care, or how would you, like, you would just make someone aware, right? And then,
Yes. So a couple things. So are you in this situation, is this person with some dementia going home, you said with minimal support, meaning do they live alone? Because that's a huge red flag right there, right?
well, right, something like that, like a situation like that, or like you said, maybe their spouse is elderly, and maybe they have some, issues as well. So, um, you know, what it's like hard, I guess, to gauge, you know what I mean? How
Right.
much help someone would need, I guess.
Yeah. So there's definitely, if you have a patient that you're caring for in the hospital and you recognize that there is some dementia, and if they're going home on one med or 10 meds, it doesn't matter. They're going home on meds, and your concern is, are they going to be able to manage those medications? So, yes, you would get involved, get the discharge plan or the. So again, there's the case manager who, one of their roles in the hospital would be to they review their charts and make sure that what their situation is, and then they would get involved either with the nurse or separate. But what happens is you get the discharge coordinator involved, and different hospitals have different models of care. So meaning that some hospitals don't have discharge planners right there. They only have case managers in the hospital. The case manager and the nurse and the team would talk about this patient, the concerns about sending them home, and then talk about maybe some other options. So there may be, so you could put in home care as one option, but remember, with home health, you have to have a skilled need. What is the skilled need? Is the skilled need because they have dementia and they're not maybe going to take their medicines correctly? You could probably make a case for that for at least a couple visits, not a whole lot of visits, because the dementia is not going to go away. So you could go in there and set up a plan or some kind of a medication. There's systems out there now where they're almost electronic systems at home where people can get their meds. You could set something up and do a couple visits that way. But long term, that's probably a high risk discharge to begin with. So you can also involve social work. Social workers get involved because social workers know other resources. Okay. So they could say, well, so it's the social worker who makes the arrangements if a patient's going to go to another, to a nursing home, or they could go to an assisted living, but assisted living is not covered by insurance. So the social worker has to do a whole financial evaluation and assessment to determine if they could even afford to go there. It's complicated, and it's hard to say, but you're on the right track here. Kirsten, by just asking that question, you recognize that this could be a potentially unsafe discharge. When somebody has dementia and they're living either alone, that's a real red flag, or they're living with an elderly spouse who maybe even themselves have a little bit of forgetfulness. So what else could we do? We could see if there's other family members, see what other supports this family has. You know, maybe the chart just lists the husband or the spouse as the you know, emergency contact, but perhaps there is you know, a daughter or son that live close by could get involved. There are new and not new, but there are other models of care. Even having somebody come into the home for private duty, the social worker could maybe arrange that, you know, maybe in the morning and then again at evening to make sure that they've taken their medicine. But private duty costs money. So all these options are either out-of-pocket expenses or you know, like home care can be reimbursed by insurance, but only for that very short-term intermittent, which I talked about in the lecture, how somebody qualifies for home health, right? Has to be a skilled need. Care has to be intermittent with an end date in mind. Patient has to be homebound, and they have to be safe. They have to have someone in that home that can, you know, or that it has to be a safe environment in terms of, are they able to manage the 23 hours when the nurse isn't there? So that's, you know, the safety concern. So it is very difficult sometimes to find the right placement or the right placement for the patient when they're discharged from the hospital, because their care can be very complex. The problem is if you discharge that person with the dementia who's very forgetful and not taking their meds correctly, chances are they're going to continue to not take their meds correctly if we don't have something set up for them, and they'll end up back in the hospital. And a lot of times they ultimately may end up in a nursing home. But nursing homes, Medicare will cover 100 days of skilled nursing care in a nursing home. Medicare does not pay for long-term nursing home care. So if a patient's in the hospital and they're discharged to a nursing home, and some nursing homes have rehab centers right there, so the patient could be discharged from the hospital to the rehab portion of the nursing home. Medicare will cover that as long as it's, again, a skilled need in the nursing home, but only for 100 days. And then what happens after that is if a person has any assets, their home or any other assets, that's what the nursing home will go after. They will make sure that they get paid by, and they're legally allowed to do that. That's how it works. They, you know, then you have to sell your home or, and so that will continue to pay. Once somebody is out of any finances or any assets to cover nursing home care, then they go, the social worker will put them on Medicaid, doing an application for Medicaid, which is medical assistance, to cover the nursing home. Not all nursing homes take Medicaid. So then it's another whole issue with a waiting list. It's really, the situation is actually not getting better because there's more people aging. And so we have to, and I believe that, you know, this is a role of, well, AARP, the Association for Retired Persons, they are really advocates for long-term care solutions. So, I mean, there is government involvement, there has to be, to try and figure out a way to care for our elderly in a manner that you age with dignity. right? Because if you run out of money, you have no money to begin with. If you're poor to begin with, a vulnerable person, or somebody who has money, but then all their assets are used up and they still need care, um, you know, they end up, either families have to take them home and care for them, which many families do. They never even, culturally, some cultures never want their family members in a nursing home. They will care for them to the very end. But then you get into the whole caregiver strain and how exhausting it is to be a full-time caregiver. So it is really, it is a problem. And of course, those that care for the elderly, that are paid caregivers, their pay is terrible. They don't even, they do the hardest work in many ways. And their pay is, if they're lucky, 10 or 12 bucks an hour, which is better than minimum wage, but it's still not great. So it's, like I said, it is a very complex problem in our country, but there are organizations and grassroots efforts to try and improve the outcome for people as they are being discharged or transitioned from one level of care to another. Private duty, most of them charge families 25, 30 bucks an hour, and they have a minimum of 4 hours. So again, once a person runs out of money, who's going to cover that? Assisted livings, most of those, the lowest probably nowadays is about $5,000 to $6,000 a month, and insurance doesn't cover it. Long-term care insurance does. You're shaking your head, Kirsten.
That's a lot of money. That's, some mortgage payments. I mean,
Oh my gosh, yes.
multiple mortgage payments every month.
Mhm. Yep.
So yeah,
$5,000.
they're gonna run out of money fast, right?
Very fast.
Right.
Very fast. Some of them, like Copper Ridge, it's a dementia care unit, but it's up here in Sykesville. There, I believe, is 10,000 a month. $10,000 a month. Not many people can afford that. Now they do, after time, will accept Medicaid once somebody no longer has him, but they don't just bring people in that can't. You have to show that you can afford to be there. So my mother was in an assisted living not far from here because my mother had very end stage dementia, and ultimately did die in hospice with because of her dementia. But the only reason she could afford it was between her Social Security and the fact that there were 9 of us and we split her care 9 ways. And that was the only way. And hers was one of the least expensive. It was beautiful. I mean, she was in a very lovely place. I would have kept her, but I couldn't. I have stairs. My mother would have gone down those stairs in a minute because she was just, her dementia was so bad. And it's a really difficult situation that many, many, many people find themselves in. So think about this, guys, when you're working in the hospital and you're caring for patients and you're getting ready to discharge them, think about where they're going and what is the support for them. It's really important. And that includes not only people support, but equipment support. And think about safety. So that leads me into talking about safety in the home. So the example you gave of somebody with some dementia having trouble remembering medicine, that is a safety concern. So what can we do to address that? So we've just talked about some of that. Another area way you could possibly address it would be to speak to the doctor about the medicines. Does this patient, particularly somebody who's on tons of medicine, because some patients, they are on 7 to 10 to 15 medications. Do they really need to be on all of them? Oftentimes, patients are not well, and once they adjust meds or take them off, half of them, they start to rally. They start to get better because every medication has a side effect. And so you guys will have the chance now, it will open up as soon as class is over. for those case studies that you'll be doing. And it's called the Beers criteria. And by looking at that, and you'll see it on Blackboard as soon as this class is over. It shows if you're on a med, on multiple medications, the interactions or possible detrimental effects between taking two of these meds, because they counteract each other, or they cause problems. So you'll see that on the Beers criteria. So whenever you have a patient on multiple medications, look at those meds and advocate. Okay. Part of your role is to advocate for this patient and say to the doctor, I'm really concerned here. I see this patient's on medication XYZ, and there's an interaction between this med and that med. What can we do differently? Or how can we reduce the number of medicines that this patient's on so that they're safer when they're discharged? Okay. So medication errors, medication side effects also account for many of the admissions to the hospital. It's all because of the medicines that people are on. So again, going back to our very first class about health promotion and wellness, if you can stay well and promote good, healthy behaviors now, you reduce the need for a lot of medications as you get older. Being older doesn't mean you have to be on meds. Some people just automatically say, oh, you're 65, you're 70. Well, what medicines are, you're not on any medicines? Really? They can't believe it. That's the way it should be. Let's stop the medications. Of course, pharmaceuticals won't like me saying that, but I'm just telling you that if we can review those medicines that the patient is on and take note of any that might be counteracting another one, and talk to the doctor to do some medication adjustments. Some of the other safety situations that we can talk about. Well, so before I go on to that, is there anything else in terms of case management and discharge planning? There are lots of different scenarios. I don't remember if I told you this in the lecture, but sometimes when you're discharging a patient, so some patients, and one of the case studies is a homeless person being discharged. Every discharge is unique and has considerations as to what's going on with this particular person and where are they being discharged to. And again, there are homeless people that need follow-up care. There are patients that may need long-term antibiotic therapy, IV therapy. Medicare does not pay directly for IV therapy in the home. If they have a prescription plan, it will cover the medication, and as long as they meet other criteria, they would cover the nurse. But there are certain components of even like antibiotic therapy in home that's not covered. So what happens? The hospital doesn't want these people in the hospital for 6 weeks or 8 weeks for IV antibiotics. So they may discharge them to a subacute rehab, which is, again, a rehab. They call it subacute because it's a step down from the hospital, but it's not nursing home level of care. And they'll continue their IVs there. The hospital sometimes will even cover the cost for the IV antibiotics because it's still cheaper than keeping them in the hospital. But sometimes when we're getting ready to discharge these people, they may have a history of drug abuse. So what are we going to do with somebody who has a history of IV drug abuse, and now we need to send them home with IV antibiotics? Maybe they came in with an abscess from shooting up drugs, but the only treatment for them is 6 to 8 weeks of an IV antibiotic. So that's a dilemma for the discharge planner and the case manager and the court and so forth. Got to figure out, what am I going to do with this patient? So, there's again different options. One being subacute rehab, where they're still under guidance and in a facility. to make sure they're not shooting up using their IV access line for illicit drugs. I had, back in the day, we used to sometimes have to discharge patients with an IV access, and they had a history of drug abuse. We would get them to sign a contract. So that would be at least having them sign a contract that they would not use drugs through this IV line. It saved the hospital from being, responsible for it. So it was a legal thing. But yeah, so there's all kinds of complicated cases when you're thinking about discharging patients. So if you're the nurse, and if you're an ER nurse, that was another thing. When in the emergency room, you have the 80-year-old lady who comes in who fell, and now he, whichever, they have a broken foot, but they're not going to admit the patient because they can go home with a broken foot. They'll put a cast on them. Is that a good discharge? Is that a safe place? Again, the ER nurses, they get on their crutches, say, see ya. They're busy, they're running around crazy. They want to, this person's being discharged. So again, it may not be the best place for an 80-year-old woman or man with a broken ankle who now just had a cast put on, but they're no weight bearing. How they're going to manage at home. And honestly, we used to see people be discharged like that. So those are the things that are important to consider with the role of case management. And then again, we started to talk about safety. I wanted to just make sure you were good on the case management piece. Okay. So in terms of safety though, with home care, with patients going home, so we talked about medication safety. What about environmental safety? We have to think about that. If we're discharging this patient, can they get up the steps? This 80-year-old who now has a cast that is no weight bearing, and they have 6 steps to get in their house, how are they going to get in their house? So is it the best thing for them? So environmentally, just thinking about your patient's home care, or they're thinking about their discharge from the hospital and where is the best place for them to go. And if they are going to go home, how are they going to even get in the house? What about when they get in the home and it's a 2-story house and there's only a bathroom on the 2nd floor? How are they going to get to the bathroom? Right? Do we need to get equipment for them? What kind of equipment? How are they going to get a bath or a shower? So you got to ask about the bathroom. So as a home care nurse, when you go in, you get an order. So the way it works is the doctor has to order home care. They call the agency, or the discharge planner in the hospital recognizes, along with the case manager, this person needs some home follow-up. They then call the home health agency, of which there are many, many agencies. Some are private, like the VN, not for profit, and some are for profit, but you don't have to worry about that so much, whether they're for or not profit. But anyway, they'll call, the patients are supposed to be given the choice. Hospitals cannot just say, well, we work with this agency, this is who we're going to send. Technically, they are supposed to be given a choice of what agency. But anyway, so the doctor calls, the patient chooses XYZ home health agency. Doctor calls the order into the agency. They go out and they do an evaluation, usually within 24 hours. But how's that patient going to manage in that time period between discharge from the hospital and when the nurse goes out? Within, usually, like I said, it's usually the next day. So you have to make sure, again, that they're going to be safe until you get there. And then when you do get there, and you do the whole home, I talked about in the lecture about the assessment, the initial visit, right? Where you do the full head to toe patient assessment. You do an environmental assessment of the home. Okay. Now, what do we include in the environmental assessment? We want to look at making sure there's adequate lighting, that there are, if the patient has to be on, use steps, are they able to manage those steps? Are there throw rugs? So we don't want any throw rugs, you know, because they could slip on them. If they have little pets that they could trip over, that could be an issue. Any wires or things like that, or that they could trip on. Working smoke alarms. The nurses actually review all of those, and there's a whole safety checklist that's part of the initial assessment form. Okay, so the other environmental safety is physical safety. Are they safe to, do they know the emergency procedure if there was a fire or something was going to happen? Do they know, can they get out of the house safely? Do they know who to call in the event of emergency? Do they know 911? You know, so have to review all of those safety pieces with the patient and caregivers in the home. The other part of the environmental assessment is the home itself. In terms of some I've been in homes where all you have is a little. I've been in homes where, oh, backing up. Can you guys hear an echo, or is it just me now? Guys hear an echo, or is it? Ophelia, can you mute? Okay, there we go. Thank you. Can you all hear me okay now? Okay. So some homes are very, very dirty. Some homes are very, very cluttered. But it's not our place to judge or to tell somebody that, you know, that this isn't okay. We have to be very neutral and provide the care as long as us being there, it's safe. If somebody has roaches or mice in their home, that's not a reason to not see them. That does not preclude the nurse from going into that home. Believe me, I was in many, 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 many homes that have, you know, well, mostly roaches. Yeah, mostly roaches. It was a problem with the one lady that I did wound care on, because when I went to get her dressings, it was early in the morning, so the roaches hadn't spread around. It was pretty bad. So that was a problem, because her dressings were, the bugs were all inside the box where all her sterile dressings were. So that was a problem. So we had to talk about that. Yeah, you're shaking your head. Believe me, some of the situations were very scary in terms of, I never felt scared for my life or anything like that. It was just some of them were, you know, not the cleanest houses in the world, but if it doesn't interfere with their getting well, we can't not see them. Does that make sense? So just because somebody's house is dirty doesn't mean that they don't qualify. The only time, and like with this woman with the wounds and because I had gone so early that morning, I was really concerned about that. So I had to, of course, in those days, we didn't have cell phones. So I had to go find a payphone on the streets of Philadelphia and call my supervisor and say, you know, we got a little problem here. So we talked to the patient, and she was able to put them in a place that, like in a container that with a lid on it to protect the dressings from the bugs. So, you know, there are solutions, but if there are serious environmental concerns, we shouldn't admit that patient to begin with. Because once the home care agency admits the patient to services, they're responsible. You cannot just, and then, you know, the nurse admits the patient, and then the next day a different nurse goes out And they're like, oh no, this is terrible. We have to discharge this patient. It's not safe. But you can't do that because the goals haven't been met, and that would be abandonment. So you have to
I
come up with a solution. Go ahead, Christine.
If it's something like they have like a cluttered house as far as like in the walkways, is that something like you can suggest to like clear out certain walkways so it's more safe for them? Or is that like overstepping your bounds?
So you can make suggestions in a way that is not rude, or, you know, if you frame it that this is a safety concern, I don't want your loved one to trip, then you could have that conversation. But a lot of times it probably won't change. Go ahead.
Okay, because I know like some houses they're just like it's not like they're dirty, but it's like boxes in the hallways or something like that where it's I feel like it would be more of a safety concerns to like move them out of the main walkways without being rude.
Mm-hmm. You can
it's
have
not calling them dirty, but I didn't know if it was rude.
Yeah.
Okay.
Yeah. Again, remember, the nurse is the guest in the home. It's the opposite of the hospital. And so as the guest in the home, you establish that initial trust and relationship with the patient and or family, where you can suggest, for safety reasons, let's see if we can maybe clear this pathway a little more. Sometimes they're not going to, though. And as long as there is a path and they can get out in an emergency, then you know, it's okay. I mean, we even yeah, pathways are interesting sometimes, but if there's, so I remember one time there was a house and it was just filled with all these old newspapers. Now that's a fire hazard, right? So you've got lots of, I mean, a lot of it is a fire hazard, really. But you can't, your goal, your purpose is not to go in there and change their lifestyle. You know, your purpose is to go in there and rehabilitate this person with goals that you established with them on that plan of care in the beginning. And that's the goal, is for them to you know, you do your teaching, the whatever it is, diabetic teaching, wound care, and they are eventually able to show that they are independent, then you can discharge them. But until goals are met, so you have goals, you have short-term and long-term goals. You, as the nurse who does the start of care admission work, talks to the patient and or family, because they're very much involved in the caregiving, if they're in that home. What are the goals for this patient? You know, let's say they have a wound, that they can demonstrate that they know how to do the wound care. Okay, so they're demonstrating wound care, doing it appropriately. Another long-term goal will be that the wound is healed. Okay. If they're diabetic, that you're teaching them, you know, how to draw up and administer insulin. You always not only teach, but then they should demonstrate back. So, so you have those goals. If it's to teach medications because they're on 4 new medicines, that's a skilled need to teach about that new medicine. But if you keep doing the same teaching visit after visit, and the patient and the family, they're not getting it, okay, then they're not meeting those goals, and you have to go back and reevaluate those goals and figure out what can we do for them to be compliant, to try and meet those goals. And if they're not compliant, or they're not able to, then it becomes just the same thing over and over again, and that's not considered skilled and necessary. So do you remember I discussed in the lecture what you would do for somebody who is non-compliant? Can you just discharge them? You can't just say, you know what, I've been here for 4 weeks and we just keep going over the same things and you're not changing. You're not getting it. I'm not coming back anymore. See ya. No, we can't do that. Okay. So if somebody is you're teaching them and they're non-compliant with your teaching, and they continue to be, you would get a contract with them that they will start to understand or change, so that it doesn't just become day after day the same thing, nothing's happening. So non-compliant patients are not willing to learn or to change what you're teaching them to change for their better health. You get a contract with that person, and that says that within 2-3 more visits, you will be independent with this, let's say, insulin administration. Okay. And they still aren't, then you can discharge them safely. Okay? You're not held accountable. It's not considered abandonment. That's what they call it, abandonment. If you just discharge somebody for non-compliance, you've got to give them the benefit of the doubt. So you can get a contract that they will comply with what you're teaching them. But if they continue to be non-compliant, then we would discharge. So that's pretty much what I wanted to talk to you about safety. Just know that just because someone's home is not what we would consider to be a place you'd want to live in, it's not our place to tell somebody to completely redo their home. But if it interferes with their care or their safety, then we have to address it. But when we admit a patient to home health, we have to make sure that they understand emergency measures and what to do and how to be safe when we're not there. Okay, they have to be safe. Some agencies, they do have security that will go, or you can go as a buddy with another one of the members of the healthcare team in that home. If it's in an area that's not considered very safe. So there are ways to work around that as well. Just because somebody lives in an area that maybe has a high crime rate or something, we can't not see them, but we have to find, like I said, some agencies will actually have security guards that will go with the staff on their visits, or the nurse goes out with you buddy up and go together. But if it's an area and there is nobody else involved and you really are afraid to go or fearful on that first admission and it's deemed not really safe, you might not want to admit that patient to begin with. Okay. The key here is if you admit a patient, now that patient is the responsibility of the home health agency as long as you're providing care. But if you go out on that first visit and you know that this is just not a safe place at all, don't admit them, because once you admit them, now that by not admitting them, that doesn't mean you just say, oh, sorry, can't admit you. This is not safe for us. You call the doctor. You still want to try and come up with another option for them. If you recognize that this is not safe, they shouldn't be there either. Okay. So in that case, you would talk to the doctor and say, you know what, I think we need to find an alternative living arrangement for this person because of these safety concerns. That patient may end up going back to the hospital just to get readmitted somewhere else where it's safe, like a nursing home or a rehab or something like that. Okay. It's it can be very complex, but it also, there's so many rewards to being a home care nurse, such as the autonomy that you have as a home care nurse. You have your schedule, you see your patients, you do a lot of work from home because you have to make phone calls, follow up phone calls, coordinating. So the nurse who's following patients in the home is considered a case manager in home health. Okay, so the home care nurse is considered a case manager when they're following a patient. Generally, nurses carry a caseload of 20 to 30 patients, but most of them only need to be seen once or twice a week. The nurse fills out their own weekly schedule, which changes continuously. So we won't have time to do it, but I will open up a case of a couple different home care management case studies for you guys. They're not like real in depth, but it will help you to know how to prioritize your patients. So you fill out your weekly schedule, but things change from day to day. So you have to alternate your schedule. Who am I going to see? Who's my priority patient? Okay. So again, there is a lot of autonomy as a home care nurse. Generally speaking, a new grad does not go into home health unless there's an agency that provides a really intense orientation. And the reason I would say don't choose home care initially when you graduate is because you need to feel more confident in your own assessment skills and your own decision-making skills. So having at least a year of med-surg background or some kind of, nursing background where you're working with patients, but in a setting like a hospital where there's a whole team, you can bounce things off each other. Whereas in home care, yeah, you can call your supervisor and say, "Ooh, here's my situation." And we do that often, but it's still a very autonomous role and you're on your own. So you have to feel really confident in that. And it's very rewarding. In the end, I did home care for over 25 years, home care and hospice. So yeah, it's quite interesting, very different role. But anyway, so some of you may be thinking about that. The other, so there's the home health care, which is the reimbursement. You understand about your criteria, right, for home care? Patient has to be homebound. What does that mean? Okay, so make sure you know what the homebound status, what that means. I talked about it, it's in the lecture. The patient has to have a skilled need. What does that mean? What is a skilled need? Okay, I talked about that. Patient has to be short-term, intermittent. So the initial plan of care is for a total of 60 days or 8 weeks. In home care, the visits start initially intense and then decrease as the patient becomes more independent and ready to be discharged. Oftentimes, you do not need to see that patient for all those 60 days. Okay, so they can be discharged as soon as their goals are met, because you do part of your plan of care, and in your orders that go to the physician, there are orders with goals. And the idea is to work towards meeting all of those goals. Okay? So that plan of care includes orders for all the services, which would be the home health aide, if they need one, to help them with personal care, the social worker, and then the different therapies, PTOT and speech. That goes to the physician. You can continue to see the patient in the home, even though you don't have the signed orders back, but usually the orders are returned to the agency, signed by the physician within 14 days. Okay. So you do have orders, but they're more or less verbal orders. Everything is computerized, so there is documentation systems for home care and hospice that are electronic. So everything moves a little quicker these days because they can electronically send the orders to the physician and then have them returned that way. Let's see. So then also the patients, some of them actually need care beyond 60 days. So we do what's considered a recertification of care. So we recertify them for another 60 days if they have a skilled need. So what kind of patient might have a skilled need after 60 days? Well, somebody might have a catheter. We used to have patients on care for years with Foley's. I don't know how much they do that anymore because there's so many UTIs, you know, catheter associated infections, but some people, and they have to have a catheter because they can't pee. They have, you know, their bladder's neurogenic, whatever. So those kind of patients, or we have a lot of patients in home on wound vacs. So if they have a really deep wound and they're on a wound vac, that could take more than 60 days to heal. So you could, if there's a skilled need, and that would be the wound vac, you know, the wound management, then yeah. So you can just do another plan of care for another 60 days. And then the OASIS form is used in every home care patient that's admitted, and there's the OASIS assessment, there's the OASIS recertified assessment, or when a patient's discharged, there's an OASIS discharge form. And so all of that is sent to CMS, Centers for Medicare and Medicaid. They track all that data. It's all electronic. They track it. They look at patient outcomes. So it is very much a insurance regulated industry. There was a period of a lot of fraud and abuse back in the 80s and 90s. When patients started to be discharged earlier from the hospital and they'd go home with home care. So all these agencies started to come into place because, oh, we could, you know, or they were hospital-based agencies. So the hospital actually owned the home care agency. So anyway, I think nowadays that the regulations are pretty tight, that there's less fraud and abuse. You know, and when I say that, documentation of homebound status. If somebody's still getting home care and they're not homebound, that's not okay. That's against the regulation. That would be considered fraudulent. But there was a time when a lot of patients were getting care that really weren't very homebound. I had mentioned in the lecture about, look at my time. Okay, we're good for right now. I had mentioned in the lecture about the fact that the documentation of why a patient is homebound should be consistent across all disciplines. So in other words, if the nurse is documenting patient can ambulate 50 feet, requiring the assistance of a walker, and then the physical therapist comes in and their documentation says that the patient's ambulating 100 feet with a walker, that's a discrepancy. So the nurse and the therapist need to talk, and either somebody doesn't know how to measure feet, and I always had trouble with that, to be perfectly honest. I don't know 50 feet from, I might know it from 100, but again, you know, so making sure you're all consistent in what you're documenting. So that, because if there's discrepancies in that, and I'm not saying falsified, no, you absolutely can't do that. You need to have a conversation with the therapist or whoever's documenting another ambulation distance, and come to a conclusion together, how you would document their how far they can walk, or with a device or without a device. Because some people may, demonstrate to the nurse that they have to use the walker. With the PT, they're not using the walker. So what's the discrepancy? And let's talk about that and figure it out. Make sure that you're consistent in documentation. Okay. Let's see. So the idea in home care is to advocate for your patient, but to promote their independence. Okay. So don't do everything for them. Show them how to manage, how to call their doctor when their prescriptions are getting low, or for their next follow-up appointment. So advocating, building that trust, supporting your patient, having a good rapport, setting goals with them, working towards meeting those goals. Those are all part of advocacy. Okay? Promoting patient independence. It's very important. That's the whole idea behind what we're doing in home care. So not everybody will qualify for home care. Again, they have to meet all those criteria in order to qualify. And so think about your patients when you're discharging them, when you're working in the hospital, and think about whether or not home care would be an appropriate referral for them to have upon discharge. And sometimes home care only needs to be in there for like 2-3 weeks just to make sure that they're okay. So Kirsten, the example you gave earlier about the person with the dementia and the medication problem, the nurse could go out there and see maybe in their own home, the dementia is not as severe. It depends on how bad this dementia is, but, just to get somebody situated and teach them all medicine, that's okay. As long as they're able to show you that they can meet the goal of independence with medication management. Okay. Does this make sense to you guys? Do you have any questions, or is it too much? Like, what are you thinking? Give me some feedback here. Do you all understand? Pretty good? Yeah, good. Okay. That's awesome. All right. So then, no questions, right? All right. Okay, so caregivers. So we'll talk a little bit about hospice. We have caregivers both in home care and hospice. Sometimes hospice caregivers are a little bit more overwhelmed because what's happening in hospice is our visit frequency increases as the patient's condition continues to deteriorate. So in home care, our goal is to decrease the frequency as the patient demonstrates independence with their care, or, healed wound or whatever, that they're independent. Whereas in hospice, our patient is going to need more intense services as their condition continues to deteriorate. Because what's the criteria for hospice? 2 doctors have to agree and sign that plan of care. So the patient has a prognosis of 6 months or less. 2 physicians have to sign and agree to that. That doesn't mean that in 6 months, if they're still alive, that we have to discharge them from hospice. We can continue to see someone as long as they in hospice beyond the 6 months if their condition is still deteriorating and it qualifies them. Did I tell you guys the example of so what are some of, well, let me ask it this way. So we have, generally speaking, in hospice, a lot of our patients are cancer patients. They've exhausted all treatments for cancer, and there's nothing else that can be done. And so then they go into hospice. But the patient has to say and be agreeable to hospice services. You can't, family may want that person to be in hospice, but unless the patient themselves agrees to hospice services, then they wouldn't qualify. Now, if the patient can't respond any longer, and oftentimes, it's not until the very, very end that a family or a patient, that they say, yes, we want hospice. It's really hard for somebody to come to the decision that I need hospice care, because it means confronting your own mortality. And that's not always easy for people. And so, and particularly if someone's, fairly young, or has, even if they're older, but have been very much a very vital part of a family and with it and complete, but now they have this end-stage terminal cancer diagnosis, so many times people will wait to the very end, and we've had people in hospice for 24 hours and then they die. And so the goal is, and palliative care really has come into full play. You've heard about palliative care, right? Palliative care is where it's not hospice, but it's very focused on the patient and quality of life and symptom and comfort management. But the patient can still be a DNR. Usually is a big change. So they could be a DNR. But anyway, so if they go in palliative care, oftentimes then they will switch into hospice at the end. Or they get into hospice care sooner, because waiting until that very last day or two of a person's life, they really aren't getting the services that they're entitled to in terms of symptom and comfort and spiritual care. So there's physical care, there's spiritual care, and so many times at the end, a patient's family will say, I wish we had done this sooner, because of the support that is provided to them. And so, again, palliative care is sort of pushing it or moving a little bit towards people going into hospice sooner. But cancer is not the only diagnosis for somebody to qualify for hospice. Okay, it can be any disease that a person has. If it's a terminal disease with a prognosis meaning in the best estimate of the doctor, and again, 2 doctors have to agree to it, this patient will not live beyond 6 months with this disease. So it could be a cardiac disease, CHF, could be COPD, it could be dementia. If somebody's at end-stage dementia where they stop eating, and usually they'll look at their albumin level and some of the labs to confirm that they are end stage, they would qualify for hospice care. So again, I think I mentioned it in the lecture, but if I didn't, both my father and father-in-law, both were CHF patients, and both of them said, I don't want to go to the hospital. I'm tired of going back and forth, getting tuned up, coming home. Okay, Dad, do you want hospice? He said, yes. He lives 10 months on hospice care, but his condition, so every time he had an exacerbation, the hospice team would come out, or they would instruct my mom. They had been given all the instructions what to do. And usually they use morphine to help with decreasing the respiration, some Lasix to get rid of some of the fluid. So it's symptom management. His quality of life, and that's the goal, is you want quality of life up until the end. His was met, as well as my father-in-law had the same exact diagnosis several years after my father had died, but same idea. You know, his symptoms were managed to the point where it was no longer, you know, the heart failure eventually was the cause of death. You know, you can only keep somebody comfortable. If they have end-stage cardiac disease, that's not going to go away. But they had good quality, and that was the idea. So with my mother with Alzheimer's, she was in hospice, but then she rallied and she was doing great. And so they said she doesn't meet criteria, and they had to discharge her. So it was several months later when she started to really deteriorate again that we readmitted her to hospice, and that time she was gone within like a month. Yeah. So it's what do we do though? Because I mentioned about caregivers and caregiver strain, and in particular, we're talking about hospice caregivers in the home. Okay, so a patient in the home is receiving hospice care. There needs to be at least one other person who can support them in the home. Okay, they can't. Generally speaking, if someone lives alone, they may qualify for hospice as long as there's a designated caregiver when the time comes and they need that. That caregiving is very stressful, can be overwhelming, particularly as a person's life, as their condition continues to worsen. And it becomes a 24-hour job. Now, hospice can provide home health aides to help with personal care, and there's volunteers that can come in to relieve some of the care. They can't do direct patient care, but they can at least be there and let the family caregiver get out and do what they need to do for themselves personally, you know, just a break. But the caregiver strain is really, it's pretty intense. So there are organizations, again, that are out there advocating for caregivers. There's caregivers alliances and different supports out there for people that are caregivers. In hospice specifically, if someone's condition is really deteriorating, maybe their pain is just, in addition to as their condition worsens, their pain gets worse and worse, and the family is just completely overwhelmed. They can't, they're exhausted. What do we do? You know, what do we do? Well, we have options for that family. In hospice, they can be transferred to an inpatient hospice facility for caregiver relief. They can, so there are inpatient facilities for people in hospice. Some of them are residential, where they go and they can live out their final days or months in a hospice residential facility. Or there's the type of hospice facility that is short term. So somebody whose caregivers are exhausted, they can't do it anymore, or the patient's pain is out of control, or if there's imminent death and the family doesn't want their loved one to die at home, they can have them transferred to an inpatient hospice facility. Insurance covers those facilities, but only for a time of no more than 7 days. Okay, so there are options for families for intermittent respite care, if you will. Some hospitals have a hospice designated area for hospice patients. So there are some agencies that are hospice agencies affiliated with hospitals. So that hospital may have a designated area, a couple beds designated for hospice patients to go in for respite. Again, usually no more than a couple days, or if it's imminently they're dying and the family doesn't want them at home. So there are different options available for patients, families that are the caregivers that are overwhelmed. And that can happen. But the beauty of hospice is there is this whole team working with the patients and the families. Like I said, there's spiritual care. So there's spirit bereavement is another component of it. Social work, the home health aide, the nurse. There sometimes are therapies in hospice, but usually it's just to show a family how to transfer a patient, something like that. Because usually therapy is considered rehabilitative. Well, we're not really rehabilitating a hospice patient. We're making sure they're comfortable to the end. So it's a little different. So let's see. That's the idea behind hospice. There is the there is a certification for hospice nurses and home care nurses, the CHPN, which is Certified Hospice and Palliative Nurse. And they really, so it's an exam, they become a CH certified, and they are really, really good with pain management. Some patients don't want to be medicated to the point where their brain is not, they're not able to still think clearly. Some patients want to be very much. They want to be medicated. They don't want to be in pain. And so the hospice, these certified hospice and palliative nurses, their education or their certification includes how to manage that pain. There are some people say, oh, hospice is euthanasia. It is not. It is not. It is keeping somebody comfortable to the end. Their morphine levels, the amount of morphine that they're given is pretty intense. If that's what the patient wants, to be pain-free. The goal, I'm looking this way because I wanted to show you a booklet I have, but I'll find it in a minute. But the goal of hospice is for a patient to have pain and symptom management and have what they call a good death. That's the whole idea of hospice, is that a patient dies, if they can be in their own home or in one of the hospice respite type facilities. But I've been at patients' deaths where they're surrounded by their loved ones. There's music playing, and it's absolutely beautiful. It sounds crazy, but it is just a transition to the next life. And it can be very, very beautiful and helpful for the family to be there for that transition. But it's not for everybody, and not everybody wants to be there for that, So the hospice team will find out what the patient's wishes are. So anyway, I have a book, and it's called, here it is, Gone From My Sight. So this book is it's in the hospice booklet. Has anybody had experience with hospice with any of your family members or yourselves working in hospice? Okay, so some of you are familiar with a booklet similar to this, and it basically it's called The Dying Experience, and it helps families and patients to prepare for what's happening. And so it talks about beginning from 1 to 3 months prior to death, as people withdraw from communication, interaction, from food, and it goes all the way through to 1 to 2 weeks, 1 to 2 days, and the physical changes. And I know Dr. Eck Elliott talks about the death and dying, so that's a separate lecture. I won't go into that so much, but there is patients are given a lot of education from the hospice team as to what to expect as a person is nearing the end of their life. And as I said, oftentimes they're like, I wish I had known about this sooner. So those were the points that I wanted to cover. Does anybody have any questions? And if not, we'll get into those. I have a couple of case studies I'm going to put you in your groups to do. Questions? You all feel pretty good about it? Yeah? Okay, good. Excellent. All right. So the next thing then we're going to do is, this time I'm going to put you in your breakout room with your clinical group. So we'll have 3 groups. All right. I have 3 different case studies, and you'll each do a different one and then report back on it. So I'll give you like 15, 20 minutes to do that. One is on, and one is a hospice end of life. One is on patient education, and the other one is on discharge coordination. Okay, so let me put you guys in your groups. How are you doing with your windshield surveys before we split up? Because I'm going to put you in groups, that way if you need to talk to each other about what you're doing with your windshields. Any questions on any of that? How's that going? Going okay? Maybe not so much, huh? Okay, let me see if I can, so I can, do you all see these case studies, classroom activities on Blackboard? Do you all have that? All right, so group one, you're going to do the one on patient education. All right, group two will do, so patient education and is group one. Group two will be the discharge coordination, community-based nursing discharge coordination. And the group three will do the end of life hospice case. All right. So let me put you into your groups. And so group one, let's see, I got to create 3. All right, so I have your list here. All right, so group one, assign manual. All right, so group one is going to be Karan. Let's see, right here, Antoinette, Ophelia. So is there 2 Ophelias? So it should just, okay, Dana and Christine, you're group one, okay? And you know what? Can you see which one you're picking up to do? There's
Antoinette
also a
is in our group
Harold
too.
case study. If we have time, we'll look at Harold. If not, I'll open it up, the answers, so you can use it for studying, okay?
Antoinette's in our group too.
Yes, so I have Ophelia, Karen, Dana, Christine, and Antoinette, okay? Then in group 2, Stephanie and Hazel and Pearl and Ari and Sony, right? All right, and then group 3 would be Angela, Kirsten, Kelly, Bridget, Caroline, and Nakia. Is that right?
Yes, I'm sorry, I have a question. Where are we finding these case studies?
Okay.
I'm
So,
sorry.
no, you don't have to be sorry. I will tell you exactly. So in the classroom under hospice, under class 3, okay? There is, I'm pretty sure I opened it. Let me make sure. Hold on. Ah,
It's there.
is it there? You see it now? Under classroom activities. So there's a case study discharge coordination. That's group 2. Case study patient education is group 1. And case study hospice at the bottom there
Thank
is
you. I
group.
just had to refresh my page. Sorry about that. I
No,
didn't see it.
no worries. Okay. All right. I'm going to open your rooms now. Okay. So I will see you in, let's see. You should be able to get this done in, I'll check in 10 minutes. Okay. All right. You've all been invited to your rooms.